This video presentation is basically a collection of the last 25 years of my educational efforts condensed into this course. And the overview for this course is, I will take you through the different sections, but airway stuff matters. And I love this quote from Mel Herbert, "What you do matters." There is nothing in emergency medicine that matters more, in my opinion, than airway. For many reasons. First off, we never, it lands on us. It's not something you're dependent on a consultant for. You have to make peace with this aspect of emergency medicine. Otherwise, you really can't make peace with the job. So it's mission critical, it's time dependent, it's required often with little preparation, little time, advance warning, and it tests your ability to control yourself in terms of how you think, how you act, also how you communicate. There's a saying that you can't control what you do if you can't control how you think. And so over the last 20 years, in addition to kind of refining what I'm going to share with you in terms of best practice for laryngoscopy, oxygenation, and all these different devices, a big piece of what I've come to appreciate is most important when it comes to airway management is actually keeping it simple, doing one step at a time, and making sure that we're actually giving operators techniques and a mindset to practice that enhances their performance instead of adds to cognitive burden. So a number of years ago, I had the opportunity to have dinner with a pilot who ran for one of the major airlines stress training and human factors training. And his name is Martin Bromiley. And he got interested in crisis performance of medical personnel because of his work in airline safety and training pilots. But his wife went for an elective surgery that did not go well. And I met him at a dinner for the Difficult Airway Society in Great Britain and Ireland, where he was the keynote speaker. And I want to share with you this video about his wife's surgical experience and basically crisis performance in airway management.
My name is Martin Bromiley. I'm dad to two young children, Victoria and Adam. And this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. I'm an airline pilot with a background in human factors. I want to make a difference. I want to be able to say to Victoria and Adam in a few years' time that although their mum died, the lessons from that have been learnt, and that there is a change in practice in healthcare in the UK.
So he tells the story about his wife's surgery.
Elaine actually had very good health, but she had suffered from some sinus problems, and as a result, a consultant had recommended that she should have routine sinus surgery. We left at 8:30 in the morning, having kissed Mummy goodbye, and went off to do the weekly food shop. I got a phone call at about 11 o'clock that morning from the ENT consultant, and they explained to me that when Elaine had been anaesthetised, her airway had collapsed.
That phrase, when she had been anaesthetised, her airway collapsed, really got my attention, because we take this 34-year-old young woman who has gone to bed every day of her life and her airway never collapsed. She delivered two kids, one of the greatest physiologic challenges on the planet. Her airway didn't collapse. Her airway collapsed because she was given a combination of medications, put in a supine position, and was not pre-oxygenated appropriately. And then, as she desaturated precipitously, the clinicians involved persisted on plastic and trachea instead of addressing oxygenation. The take home from this case historically has been, Well, the operators should have cut the neck sooner. But I would suggest to you that it's a much bigger lesson. And the much bigger points have to do with oxygenation. So for instance, this is a 34-year-old who has a pulse oximetry reading of 100% on room air. They look at her, she's not overweight, her airway appears normal, so they didn't anticipate any problems. And what that meant was they did not pre-oxygenate her. Now, we have this illusion that when we put people to sleep or they stop breathing, they're going to have 4 minutes of safe apnea. But in fact, we breathe 21% oxygen. When we then lay flat, our FRC is significantly decreased. So what you wind up with, and we're going to go over this when we get into the oxygenation segment of this course, but what you wind up with is roughly 400 milliliters of oxygen in your lungs. Now, we draw down about 250 milliliters of oxygen a minute. So your safe apnea time without pre-oxygenation is about 90 seconds. And as they were putting her to sleep with propofol, the plan was give propofol, put in a laryngeal mask airway. But what ended up happening was they couldn't get a good seal. They didn't get effective ventilation. And they persisted, and then they gave more propofol, which usually facilitates proper placement of a supraglottic airway. But when they gave more propofol and they still couldn't get it in, they then decided to give her muscle relaxants, namely succinylcholine, and attempt to intubate. And they had trouble doing that. And so what ends up happening is this elective case quickly becomes life and death. And it took 8 to 10 minutes, and then they kept doing the same thing. And what happens is they get stuck in what's called a goofy loop, or stuck on stupid. They're doing the same thing over and over and over. And we see that in this next video. And people think that what should have happened here is actually, they should have recognized this as cannot intubate, cannot oxygenate, or cannot ventilate, and that they should have cut the neck. I would argue there are many other things, simple things, that could have been done that would have saved her life. And we're going to go over this in this course. But it's just interesting to think. These are senior people. They have extensive experience. They've gone to difficult airway meetings. You have ENT surgeons, who pick up scalpels for a living, who didn't act in a manner fast enough to save her life.
We know that 2 minutes in, Elaine's oxygenation was 75% and falling. And she was, by this time, already visibly blue.
A failure of pre-oxygenation.
Within 4 minutes, we know that her oxygenation had fallen to 40% or lower. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower, the heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempts to intubate, and they used a variety of different techniques and a variety of different pieces of equipment. The nurses, meanwhile, performed some tasks under their own initiative.
And you have these senior operators.
What we can say is that 10 minutes in, with hindsight, this is a situation of can't intubate, can't ventilate.
So you have these senior operators who fail at placement of an LMA and getting a good seal, who fail at laryngoscopy and intubation. And then what ends up happening is they get other people in who then attempt it themselves. And, you get this, basically, they're doing the same thing over and over. And this is at a moment when you have very little time to save this patient's brain. Ultimately, they were able to get her somewhat oxygenated, and the next day, she was declared brain dead. But this all happened from an elective surgery in a 34-year-old with no anticipated difficulty. And it goes to show you, it doesn't really matter what you know. I think in American medicine especially, but just as physicians in general, we're led to believe that the smarter you are, the better you'll do. But what I've come to appreciate is it doesn't matter how smart you are. It matters what you can do in the moment. And in fact, smarts or worrying about everything all at once or thinking through all these things, that's not how you do well in medicine. I think what the best operators do in moments of crisis is they keep it simple and they do one step at a time. But you know, this business of intubation, this business of airway management, where drugs go in and all eyes go on you, where I currently work, I'm a recovering consultologist. I spent 25 years in inner city, high volume, tertiary care centers, and now I work rural critical access. It's me and 2 nurses. And when those drugs go in, it's just me. There is no backup. But in our brain, at every moment that we are functioning as emergency physicians, we're gauging the perception of the demand of the situation in our own head and our perception of our own ability. And it's this balancing act. When the perception is that demand exceeds your ability, you get stressed. And when you get stressed, your heart rate starts to go up and you feel this ba-boom, ba-boom, ba-boom. Your mouth dries out, your pupils dilate. When you look at that video of these people doing the same thing over and over and over again, they are like deer in headlights. And they're not thinking right. And we now know from studies of stress that what happens in these moments is literally visual perception goes, audio perception gets worse, your heart rate goes up. And so there's these physiologic aspects of stress that begin with, at first, this perception in your head that demand exceeds your ability. So the game becomes, in this critical task of airway management, how do you control your head so you can do well with your hands? And crisis performance, very impactful on our self-image. You know, we don't get that airway, we feel like crap. We feel only as good as our last one. And if you don't manage these points of the sharp end of this job of emergency medicine, if you don't manage it well over time, I think that contributes to burnout, fatigue, and shortening of careers. So Yerkes Dodson in 1908 started looking at stress and actual physical effects of it and came up with this curve that relates to that as you have more awareness and you get focused, that's good, but you get to a certain certain point of stress where afterwards it actually becomes overwhelming and you do poorly. So when perceived demand exceeds perceived ability, things go south. Heart rate, vision, hearing, cognition. And that's exactly what happened in Elaine Bromiley's case. So, you know, this is some stuff that has been out there. A lot of this was developed in the military, actually. And you know, how do you perform well when it's life and death? And you need some stress, but if you have too much stress, if your heart rate gets too high, you lose fine motor control at about 115 beats a minute. So that yellow zone of 90 to 115 is right on the edge. You're starting to get amped up, but north of 115, fine motor control starts going. At 120 to 145, it's evident that you have tremor and your coordination goes. I mentioned that dry mouth. I've had that experience many times during my early years in emergency medicine, that when people were really sick, and especially stressful situations with children, for instance, I'd notice how dry my mouth got. But at 115 beats a minute, that peripheral vision goes. You don't hear things. You can't focus. And think about the tasks of airway management. They involve fine motor skills, visual, perception, that requires real concentration, and you're listening in terms of what people are telling you about oxygenation, but also monitors and other things. And so as that all deteriorates, it goes south. Above 175 beats a minute, things really go bad. Like even to the point of losing bowel and bladder function. You know, it's estimated that in combat, maybe as many as 1 in 4 soldiers in combat soil themselves from that stress experience. But obviously, in combat, it's life and death, and if you don't perform well, you're dead. In emergency medicine, it's life or death. You don't perform well, the patients do poorly. But I worry about how, as a specialty, we have not trained operators to really confront this crisis performance challenge of how to balance perception of demand versus ability. And this course is designed to help improve that balance and to keep it at a level that you feel you can do the next step and that you don't have this perception that you're exceeding your perceived abilities. So, the other thing is that how we actually do in these moments of crisis, behind our visible performance that everybody else sees, behind that is this internalized aspect of this, your own self-control, how you think. In order to do well in crisis performance that is visible to all, you have to do well here. As I mentioned, if you can't control how you think, you can't control what you do. Another way of saying that is if you don't control how you think, you can't control your hands. And it's the same with your speech, by the way. When you watch clinicians who are yelling, who are getting all worked up, it's clear they don't have that self-control. But this is a pyramid, and we're looking at the top of it in terms of crisis performance and how we intubate and how confident we are doing it and how slick we make it. And, that first pass and done. But beneath that has to be self-control and an engineered practice designed for first pass success. And that's what a lot of this course is about, is designing practices that make operators perform better. And then down, at the foundation of this all is this understanding that we have a unique job. We have a unique challenge. Emergency medicine is not normal in any way, shape, or form. To go to work every day and have people dying in front of you, not sure what's coming in, and be able to respond to that. It took me many years as an emergency physician before I had enough insight to my own anxieties and just, stressors that were going on in the moment. And what I've now come to believe is that not only does this involve thinking in a certain way that makes me perform better, but I now actually engineer my practice with an understanding of how stress factors in so I can do better. So a lot of what we're going to be discussing in this course is about how to get this balance right, but the things on the right side of this screen, our perceived abilities, they hinge on insight into understanding, for instance, the best way to expose the larynx in a reliable fashion every time so that we're not in hit or miss mode. To have an engineered and an incremental approach so that in our brain we can just do one step followed by the other. And then there is this self-talk, this internal dialogue. And I'm going to be throwing a lot of terms at you, but the terms are they're not simply, bimanual laryngoscopy, or they're not simply, straight to cuff stylet shaping or uvular point step epiglottis. I'm saying these things, they relate to a procedure, but they also are confidence building, simple terms that are kind of mantras to guide us from one step to the next. And so after this internal dialogue is obviously our external dialogue. And all of those things, you have to improve those abilities so that you can deal with perceived demands. And by the way, algorithms, I think, add cognitive burden and are not realistic in crisis. And they're not how people think. And I think instead of algorithms, we should focus on airway priorities. And that's what we're going to do. So this course is not a deep dive into some algorithm where you're supposed to do this step followed by that step. I think that is not how humans practice. And I think any algorithm that you look at with 6-point type and you have to squint to read and has 1 million boxes is not realistic for emergency care. So getting back to this issue of how we perform in crisis, and there's a picture of me in a resuscitation involving a morbidly obese man who was a known difficult airway. And is everything you fear in terms of airway prediction difficulty. But one of the things that I've come to appreciate is that there is a narrative, a way we're talking to ourselves in these moments of crisis. And some people call it self-talk. But there was a fellow I met by the name of Michael Askin who shared with me this acronym of self-talk for enhanced performance under pressure, or STEP UP. And what do you actually say to yourself when you're doing a critical procedure and it's life and death and you have to perform well? Well, I have come to appreciate that it's good to get yourself in a mindset that is going to enhance your performance instead of deteriorate it. If you go into these critical things going, oh crap, oh crap, oh crap, you're not going to do well. You have that 6-year-old who's seizing in front of you, the parents are in the corner of the room crying, the nurses are looking at you, and you have to get that airway. If you go into that saying, oh, I haven't done a pediatric airway in X years, I'm scared about doing this, I don't know if this is a good idea, you're not going to do well. But instead, if you're able to go into that airway and you're saying to yourself, I'm prepared for the challenge, and I think about all the time I've spent preparing for this, all the airway courses, all the self-study, all the video imaging I've done, my teachers are here with me. I think about people I've met along my journey as an emergency physician, airway educators, airway device inventors. But I envision, while I'm doing this airway on this 6-year-old, how much time I've spent preparing for this moment, that my teachers are here with me. I am absolutely convinced that I am acting in my patient's best interest. In the past, I would see surgeons commanding trauma resuscitations, yelling at people, and I thought it was this kind of combination of arrogance and, just being like, very headstrong. But now what I realize is that if you're a surgeon and you're taking a knife to another person, you better believe that what you're doing is right. You should not go into any procedure with doubt that it's the right thing. So if you're picking up an instrument to do a procedure and in the back of your head you're saying to yourself, I don't know if this is the right thing to do, you probably shouldn't be doing it. You want to be all in. You want to convince yourself, and you have to believe fundamentally that you're acting in the patient's best interest, that you're committed to it. As the pilots say, I'm all in. Another way of thinking about that, the pilots say is, they hit the ground first. So they're all in trying to deal with the flight emergency correctly. But then the other thing that happens after this, I'm prepared for the challenge, my teachers are here with me, I'm acting in the patient's best interest, I'm all in. The last piece of this puzzle is it's just one step at a time. And that's what I've learned is the most important thing to doing well in crisis. You don't control your fear. This notion that we can just say, oh, we're emergency physicians, we're prepared for this, and you try to puff yourself up. But if the internal dialogue is, oh shit, oh shit, oh shit, excuse my French, but if that's the internal dialogue, you're not going to do well. So I now believe that we don't confront fear, we unload it. You literally unload fear through insight into understanding how to get things done, keeping them simple, keeping them incrementalized, and engineering a best practice. So I now believe that the best operators actually are not the best performers of a difficult, complex procedure. What they've done is they've broken down complex procedures into highly incrementalized, best engineered practices that they then can do one step at a time. So the goal of this program is to focus on simplicity and reliability, reproducibility, that when you pick up the laryngoscope, whether it's the glide scope hyperangulated, whether it's a CMAC conventional shape, whether it's an endoscope, whether you're cutting the neck, we want to keep the handling of that instrument, that handling, the approach to that technique as simple as possible and as reproducible. And I call it incrementalization, that we're going to take each step of these procedures apart. And what I think the best performers in the world, whether it's Alex Honnold climbing in Yosemite, whether it's Shaun White doing triple flips on a snowboard, whether it's Michael Phelps in a pool, You take a look, Simone Biles on a gym mat. These people, they take highly complex tasks, but they've practiced it over and over. And it seems so fluid, but in fact, it's just a whole bunch of tiny little steps practiced over and over until it just flows. So we're going to be sharing with you what I call sticky terms to help in our training and our sort of messaging about this. So for instance, one of the ones that I like is, uvula points to epiglottis. So when we go in with a laryngoscope, you look down and there's the uvula and it's pointing towards the epiglottis. And that, as I mentioned, not only does it's critical that you realize the importance of midline and the reliability that uvula leads you to the epiglottis, but also it's kind of a affirmation that you got this. Uvula points to epiglottis. But we want to augment our self-talk so that we feel more comfortable and more confident and we do better. So the sections we have are patient safety, which is going to go over algorithms of prediction of difficulty, which I am skeptical of is going to improve performance or safety. But I'm going to share with you my take on patient safety, and a lot of that has to do with oxygenation. So, there are three main risks when it comes to airway management. One is oxygenation. Two is avoidance of vomit and regurgitation and aspiration. And then three is hemodynamic stability. And those are the three priorities that we're going to cover in the patient safety area. The anatomy piece, I think we have underaddressed. We consider it okay that when we start out as emerge docs to kind of learn as you go. But I think actually if you front load anatomic education, it's way better. We're going to go over direct and video laryngoscopy, and they're not that dissimilar. And the principles of good laryngoscopy for direct apply to video laryngoscopy. We're going to mention and show a bunch of cases in children, which are more stressful for us because we're humans, but, and the nurses, they like the little people especially. It's hard to blame a kid. I think in emergency medicine, when we deal with bad outcome, sometimes we kind of not dismiss it, but we look at it and think, oh, well, this person's old or this person's obese or, think about like Elaine Bromiley. In that video, they said her airway collapsed. They blame the patient. I think sometimes in the airway game, or sometimes just in general in the emergency medicine game, we blame the patient. In kids, it's hard to blame the patient. So they are gut-wrenching in terms of our, we want to do the best we can for these kids, obviously. Endoscopy, which is something relatively new in emergency medicine. A lot of clinicians are not that good at it. And it's a rarely used skill, but it will improve your confidence tremendously in airway management if you are comfortable doing quick rhinolaryngoscopy, and if you can, do a long scope intubation. We're going to cover special challenges, things like epiglottitis and tumors and masses and stenosis and anatomically difficult airways, physiologically challenging airways. That's going to be covered in the special challenges section. And then lastly, we're going to take a long look at surgical airways and specifically cricothyrotomy, because that is something that if all else fails, and in some instances we need to lead with when it comes to the airway management. So, massive facial injury, other things, rarely necessary, but critically important that operators get comfortable with that. Anyway, that is our overview of the course, and we're going to jump in and start with patient safety as our first segment.